copy this presentation so that I can do some editing in yours.
Hello, Prem.
Hello, ma'am. How are you?
Yeah, I'm fine. So we're waiting, Ranjit. Somebody is there.
Madam, how are you?
Yeah, you're there. Huh? Okay.
I'm there, ma'am.
So I'll introduce you, Ranjit. You have to introduce Prem because you're the moderator, chairperson.
Okay, Prem, tell me what should I introduce
Hey,
you?
the slide will come, yeah. Slide will come.
Oh, slide will come, okay.
Rest you can add, whatever you know.
Rest I can add. Oh, that all bad things you know about him.
Yeah.
Just a minute, I'm just connecting my camera.
Okay, connect. 5 minutes.
Ma'am, the sessions are going very well. Very nice.
Yeah.
The selection of topics, the talks, they are really, really very nice.
We have very good scientific committee.
Yes.
We have very good speakers who all agreed also, like you.
Yeah. Thank you, ma'am.
The advantage of online is you can get good speakers.
Yeah.
Because they have time. But when it is a physical meeting, then the problem is the time for them to travel.
Yeah. Yeah. And also it becomes more expensive to get a lot of people.
Correct. To get people is also expensive.
Hi, Ranjit.
Hi, Prem. Hi. Good to see you after a long time.
Good to see you too.
This thing on the go was nice. Therapy on the go, those apps, no?
Mm-hmm.
Yours means medals.
Mm-hmm.
Ma'am, we're all ready. So
yeah,
whenever you think it's appropriate, then we can start.
No, I'm just looking at the time.
We've got 5 minutes more.
We have 5 minutes.
Go sharp because people will miss, no? They'll also look at the time and come.
Correct. We'll wait, no problem.
They're hearing it test box, Ranjit, there.
Yes, ma'am, that's the
Phonics
8000. It's no more in manufacturing.
I know, Phonics has closed.
Yeah. Because the George Fry died, I believe, ma'am. He passed away.
Oh, okay. He was
And
only
his wife,
doing it, is it? Huh.
Yeah, he and his family, his Kelly, his wife, I think his Kelly is with dementia, Parkinson's. They're quite old. They don't have any successors. So I think they sold it to a Japanese company now. The Japanese company is now revamping the whole.
They might start.
Yeah, but the Phonics is one of the best analyzers.
Yeah, very good.
Very sturdy.
Yeah.
I've been to their lab twice.
So Ranjit, how is the situation in Chennai with the rains and all?
Much better now because the rains have stopped since day before yesterday evening.
Oh, really? Good.
Madam?
Thank God.
Madam?
Thank God, I said.
Oh, yes, of course, ma'am. So the weather is okay. Today we could see some sun.
Wow. Yeah, that looked very, very bad on the news.
Chennai was, very bad.
Yeah.
Yesterday there was one guy who died electrocuted right opposite to our institute.
Oh.
He died 1 second, just like that.
Oh. Not good.
Very uncertainty.
Mm-hmm.
He just walked out of his bus stop to his work, put his first foot on the ground, died.
Oh, he was dying. Oh, he was. Oh, the bus was insulating him.
No, he was. There was water clogging, stagnated water, and there was an electricity leakage from the transformer.
Correct. But in the bus, he won't get because the bus.
In the bus, no, he's safe.
Right.
You don't have any contact with the water.
So, let's start.
Prem, first you start with your Ecap, ESRT and stuff.
Yes. I didn't include ESRT.
Sorry, Ecap, IFT
Ecology and art. Yeah, IFT, ecology, art.
Yeah, correct. Sorry. Because nobody does ESRT interop nowadays.
Hey, we should do. Okay, I'm going. Okay, Ranjit, you have to you see the program, no? You have to introduce Anandan Dhanasinghan and
Anandan Dhanasinghan, Peter Knopp.
Yeah. Slides will come, so you get the slide.
Okay. Yeah, ma'am, is it possible to send the slides earlier so that I could read about them?
Yeah. He said he'll arrange.
Yeah, so that it's easier. Otherwise, reading a biodata becomes monotonous.
You heard what he said, no?
Karen's talk was very nice, ma'am. Fantastic experiments they have done.
Yes. All are very nice.
I was wondering, when will we have those kind of facilities in India to do those?
I know.
Funding.
Only. Somebody should fund. We should try. Now DST is closed down. Earlier also we should have tried. Okay.
DST is their funding, what they give to you. Yes.
I think I have to do share. 1 second. Oh my God. Share screen has not come. Good morning, everyone. Oh, wait a minute. Share. You will share that. Good afternoon, everybody. We now begin the afternoon session, which is only for audiology, on intraoperative measures. The session is chaired by Mr. Ranjit Rajeshwaran, and he will introduce Mr. Prem Ranjan to you. So Ranjit Rajeshwaran is Professor of Audiology, Director, Murph Institute of Speech and Hearing. He's a Chief Audiologist in the Murph Foundation and Director in Hearing for Life, President of the Isha chapter of Tamil Nadu, and Vice President, Cochlear Implant Group of India. Mr. Ranjit has a long experience in implantation audiology, 23 years. His areas of interest are in implantation audiology, auditory neuroscience. He's received the Best Teacher Award by the Tamil Nadu Dr. MGR Medical University, Distinguished Alumni Award by Sri Ramchandra University. Mr. Ranjit has submitted his thesis, Application of Auditory Evoked Potentials in Auditory Brainstem Implant. He's a member of several organizations. He's a founder member of the Cochlear Implant Group of India, founder member of Hearing Group, and a member of the Indian Speech and Hearing Association. He has initiated several programs. One is the Cochlear Implant Education Program for Parents in 2000, the first Auditory Brainstem Implant Program in 2004, and the Postgraduate Diploma in Auditory Rehabilitation at the RCI. He also has programs, cochlear implant programs in Sri Lanka and FMC in Nigeria. He's a special appointment. He has special appointments, like he's a member of the advisory committee of the RCI, member of board of studies in the Tamil Nadu MGR Medical University and Jerusalem College of Engineering, and has guided more than 57 PG theses and published several articles. Mr. Ranjit, please take over the session.
Very good evening to everyone. Thank you very much, madam, for this nice introduction. And I would like to thank CIGI and the organizing committee for giving us the opportunity to chair this excellent evening, which has got two major components. One is on intraoperative measures, which is going to be for 60 minutes, which Mr. Prem and myself will be doing, and followed by Dr. Anandan Dhanasinghan, who is an expert in electrode designs, and then Peter Knopp, who's an expert in sound coding strategy in cochlear implants. So with that note, I would like to introduce Mr. Prem Ranjan. Can I have his introduction slide, please? Yeah, Mr. Prem Ranjan is an audiologist. At the moment, he is working at Medal in Austria. He holds a master's degree in audiology and speech language pathology from the University of Mumbai in India. He is currently working as an advanced product manager of electric acoustic systems at Medal headquarters in Innsbruck. He has over 15 years of experience in the field of audiology, especially in cochlear implants. And he has got work experience both with engineers and also collaborating with ENT surgeons, audiologists, patients, researchers. And he has traveled all around the world on different and has worked on different types of implantable hearing solutions. And he's also presently working on some of the very novel methods of measuring the auditory evoked potentials, which is intracochlear electrocardiography, which is a very novel objective measure, which you will be hearing soon. He will be presenting about it. And he's also, we are also very proud to tell that he's one of the Indian prodigy who's working in an implant company where he has designed a lot of devices and where he has did a clinical trial for various devices which we are using at the moment. One such device is a medical device app, which is established now. So Prem, thank you so much for joining us. It's very nice to read your CV, and it's good to have you back on board and CIGI after 2 years. Over to you, Prem.
Thanks a lot, Ranjit. Thank you so much. Thank you, Madhuri ma'am. And I would also like to thank the organizing committee of CIGICON to really give us the opportunity to present in this forum. And I would like to welcome all of you in this session of intraoperative measurements. I would very shortly share my screen to bring up the presentation. Can I have control to share my screen, please?
Mr. Prem, you can try now.
Yes, thank you. So here we go. So we are going to talk about the intraoperative monitoring and I am going to give you information on the impedance and field telemetry, the electrocardiography measurement, and the auditory nerve response telemetry. I know that many of us here in the audience are very much experienced with these measurements, and I would only like to bring your attention to some of the facts which we sometimes overlook, or we sometimes just the operating room, the operating theater condition is so tense that we sometimes don't really realize that there are a lot of things that we can contribute during the measurement and also help the surgeon to understand what is going on during the electrode insertion and once the electrode insertion is complete. So basically how we can contribute in this is by doing these measurements to confirm the proper functioning of the implant hardware. So we need to understand that the implant hardware is working within specification and the electrode insertion has been good. We can also help in monitoring the hearing preservation in patients who have residual hearing at the time of surgery. And we can also assist and help in confirming the placement of the electrode in the cochlea. So these are basically the objective measurements, which are non-invasive in essence, and we can do it with minimal requirement of external hardware. And we will see how we can achieve all of that. So starting with the impedance and field telemetry, also in short, we refer this to as IFT. So what telemetry means is basically it's receiving the data from the implant to ensure that it works within specification. And also telemetry typically means that there is also some component which is involved, which is kind of non-contact basis. So how that happens is we are going to collect the data from the implant in the sense that we will monitor the coupling. And what that means is that we are going to place the external coil on top of the skin, which then communicates with the implant's receiver stimulator. So this is the telemetry, what we're going to do. So we will confirm that the coupling is good. That is because if the coupling is not good, then the reliability of the measurements, what we're going to do is not very good. And it's difficult to trust those measurements. So we need to, first of all, start with the coupling measurement. And then we do the integrity of the implant electronics. And this is the part of the implant which has been placed inside the skin over the skull. So this is what we will also measure during this telemetry. And the third component is the integrity of the active electrode array, meaning that we are going to measure the electrode impedances, we're going to measure the ground path impedance, and the voltage field along the cochlea. So this is where we will focus exactly on the status of the electrode array, which is now sitting inside the cochlea. So the telemetry, the impedances which we obtain during telemetry is not only important during the surgery, this is also important and it is very much required during the fitting. And please also, we must keep in mind that the telemetry must be conducted not only before, so even before we open the implant, we can do a telemetry just to assure and confirm that the implant which you're going to open in the operating room is good to use. And then after the implantation, and of course also every time when the patient comes to you for a follow-up, we must do telemetry because these telemetry values will also influence your fitting aspects. This is how you see the telemetry measurement window in the Maestro software. It kind of indicates you and it guides you that you need to do the telemetry. As you can see, it says it's required. And you click the measure button as shown here, and this is how you see the telemetry values. So in the bottom part of the screen, you see all the exact values which were measured. So these are in kilo ohm typically. The status below that, it shows all okay. And a very nice indicator is also the green tick mark. So visually, you immediately understand that yes, the status of all the electrode on the electrode array is fine, and you're good to go and move to the next step. The next step is looking at the voltage matrix. Now, this is something which is very interesting. And I must tell at this point that this measurement is available with the Medels fitting software for years now. And what you can see is that we measure the entire field of the current spread over the electrode array inside the cochlea. And we on the x-axis, you see the measured channels. On the y-axis, you see the stimulated channels. And basically, we stimulate on one and measure on all the other channels and do it for all electrodes right at the time of telemetry measurements every time when we do it. So when you look at the voltage matrix, you can see it as bars, what you can see on the left side. And if you also want to see it in numbers, so like if you are interested in looking at the exact values, you can also click on view as numbers where you see the absolute values. Now, important here for us to understand is that there is this diagonal line, which you see in light pink. So the diagonal values have a value. And what is important to know here is that all the values, so all the rows on the left side of the diagonal value should be less than 50% of the diagonal value. Why is that like this? Is because if the value on the left of the diagonal is 50% or more, that would typically indicate a short circuit between those channels. I will show you some examples. So here, how we look at the implant condition. So you see that the coupling, it shows okay. So the coupling was the first part, which means now that if the coupling is okay, then you can rely the measurement, what you've done. It shows the implant serial number. Just for safety reasons, I had to delete the implant serial number, but of course, the software will read out the implant serial number from pulsar implant onwards. So the implant sends out its serial number to the software, which you can see here. And then you see the implant integrity. If it shows okay, this means that the implant electronics is working within specification, which is good. The next thing what you see is the exact impedance values in numbers. So you see all those values are shown in kilo ohm. And then you see the status. As I told you that if it shows okay, that's very good. You may also see high or low impedance or high and short circuit, which I will show you in some example. And this is the value of the ground path impedance, which is basically the reference electrode for the implant stimulation, which is a number which is basically calculated when we have 4 or more okay channels, impedances channels on the electrode array. So how do we interpret it? So now here comes one example where you see that the most, so in the middle implant, you see on the left to right is apical to basal. So left is channel number 1 and the top right is channel number 12. So we are looking at from left to right apical to basal channel. So channel number 1, most apical here in this example shows high and the value is shown as more than 22.6. What that might mean during the surgery is that there is a probability that there is an air bubble, which is inhibiting the nice movement of the electrode in the cochlea. Or there are some tissue properties around the electrode contact, meaning there might be some blood clot or some tissue which is sticking on that electrode contact. Or the worst could also be that there is a broken wire, meaning that the wire connecting to the channel number 1 is broken. Next, what you might also expect to see are short circuits. So the high impedances may occur on one channel or more, depending upon where the tissue is lying or where there is air bubble or whatever. But short circuits typically express in more than one channel, because short means that 1 or 2, so 2 or more channels are shorting or they are kind of communicating with each other. This is not a good thing, but this is how you see it in the software. So in this example, channel number 1 and 2 are shorting. Also, you see that probably you might also see that there are more channels which are shorting among each other. And here you see that when you go to the voltage matrix, you clearly see that the values on the left of the diagonal are higher. So this is just in a nice visual representation, which you can already appreciate that the bars are higher means that they are 50% or more, of course. So these channels are shorting among each other. And if you also go and see them in numbers, so you can see for the short circuit A, the value on the left, you see 0.64, which is of course, 50%, more than 50% of the value of 0.67, and so for the short circuit B channels. Here in this example, you see the ground path impedance as 1.01, which is good. And you also see, you might see ground path impedance as 10.16, which is not good. So we want to see the ground path impedance for the titanium implants typically in the range of 3 kilo ohms. So once we have ascertained the impedance properties of the electrode array, then we can help the surgeon. Also, if the patient has residual hearing, then we can do something called as this very novel measurement, which is the electrocardiography measurement, with the help of the implant electrode array. So why we can do it, why we may do it is for intraoperative monitoring of intracochlear potentials during electrode insertion in a hearing preservation surgery. And of course, we can also do it in follow-up recordings, which is post-operative recordings in the clinic. So this concept is not new to you, not new to us. This is something what we do very routinely in the clinic. So electrocardiography is basically, it is understood that this is the response from the outer hair cell and also of the basilar membrane movement. And what changes when there is an electrode array in the cochlea is that we will stimulate still acoustically. So we will stimulate a certain frequency. We will give a tone burst at a given frequency. And we will record the cochlear microphonics not with an external microphone placed at the ear canal, but the recording will take place on the electrode array. This is what changes when there is an electrode array in the cochlea. The setup is very simple. We need an acoustic stimulator, which will be used to deliver the acoustic stimulation, and the recording will happen on the electrode array in the Maestro software. And it is also very nice to know that this is a triggered stimulation, meaning that we can really do very precise stimulation. This is how the setup will look like. So at the time, right at the beginning, when the patient is being induced, we will put the insert ear receiver in the ear canal, as you can see on the left side. And on the right, you see in this example that we are using a Nicolette system to deliver the acoustic stimulation, which is on the right side. And on the left side is the Maestro software on which we will do the recording. So here you see an adult patient. Not only on adult patients, we can also do it on small children. And not only that, we can do it on one side, but we can also do this measurement if the patient is being implanted bilaterally at the same time. So what we are going to do basically is, so in this example, you see, this is a real recording of an adult patient where a Flex 28 electrode was used, which was inserted completely in the cochlea, which means that the electrode was inserted to a depth of 28 millimeters. And the acoustic stimulation of 500 hertz was used. So the measurement started when the electrode was kept right at the round window. And you can see in the graph that it is flat, which means that there is no recording of the cochlear microphonic, which is what we will expect at this stage. And then you see that as the surgeon advances the electrode in the cochlea, you see that the amplitude starts to increase. And at the time of full insertion, that we still see that the amplitudes are preserved, and we see nice cochlear microphonic measurement till the end of electrode insertion. What this might indicate is that even after the electrode insertion, the outer hair cell functioning was probably preserved, and that is what results in the preservation of the residual acoustic hearing, and that we can see in the preserved measurement of the cochlear microphonic amplitude. So in this study, the surgeon, the outcome, the conclusion was mentioned that the novel approach using electrode array to detect and measure the intracochlear microphonics during cochlear implant surgery shows promise as an instrument to alert surgeon to hair cell damage during electrode insertion, which is a very nice thing. What we are seeing now on the field is that more and more patients with residual hearing are being implanted with cochlear implants. And then it becomes very nice and very important for us as audiologists to to help the surgeon in assisting to understand the preservation of the residual hearing at the time of electrode insertion. And as I mentioned, that not only during the surgery, we can also do it post-operative. The setup will remain the same. And as you can see in this example, that we measured the cochlear microphonic. And here you see that at 80 dB, the waves were not that great, but at 85, the amplitude of the cochlear microphonic was good. And then when we looked at the patient's audiogram, his pure tone threshold measured behaviorally was also at 85 dB at 500 hertz. And in this study, the author mentions that when you measure the cochlear microphonic at the same appointment, so when you do the pure tone measurement and the cochlear microphonic measurement at the same appointment, then they have very high correlation, and a good correlation exists at 250 and 500 hertz. Just to keep in mind, not to compare the cochlear microphonic and pure tone measurements done at two different appointments, because then these might change because of unknown change processes. This brings me to one more measurement which we can do in the OR, in the operating room. And again, this requires very minimal hardware setup from our side. So we don't need any specialized setup. And what we can do in the auditory nerve response telemetry, as we call it at MED-EL, but this is basically the measurement of the electrically evoked compound action potential, which is basically the first form of the ABR. So this is scientifically, technically, this is the Ecap signal. And what we are going to do is when there is an electrode placed in the cochlea, we will stimulate at a frequency at an electrode, and we will measure the responses, the Ecap responses on the adjacent electrode. So when you stimulate at a particular site in the cochlea, the nerves get stimulated and then it travels across, and then we can measure the potentials on the adjacent electrode. So typically, we are talking about the Ecap duration of about 1 millisecond. We are looking at the N1 and P2 peaks, which is in the amplitude range of few microvolt to 2 millivolts with a latency of about 150 to 300 microsecond. The typical sequences, what we do during the measurement is the amplitude growth sequence, and it's very easy to understand. This is nothing difficult or nothing that sophisticated. All we are going to do is we're going to increase the amplitude of our probe tone, and with the increasing amplitude, we expect to see that the amplitude of the response, Ecap response, is also increasing. Very simple. So this is what you see. So if you look at the right side of the graph, the stimulation amplitude is on the x-axis, and the way the stimulation amplitude is increasing, you see a very steep increase in the amplitude growth of the Ecap signal. This is how you also see the measurement in the Maestro software. Another typical sequence, what we can do is the recovery sequence, which is again something what we know very nicely when we studied audiology. It's that when we give a masker tone and then we give the probe tone. So basically, if the masker tone comes closer to the probe tone, the nerve is going into refraction, and therefore the Ecap signal will be reduced if the masker and the probe tone are very close to each other. And this is how we will see it in the interpretation window. So on the right side, as you see that on the x-axis, you see the interpulse interval is increasing. So as the interpulse interval increases, the nerve is not in refraction anymore. And so you see the amplitudes of the Ecap increase. And one more measurement, what we can do in the art task is the spread of excitation. This is a very nice measurement, and here the similar concept of the increase of the Ecap amplitude, what we will utilize and what we are going to do here is that we will give a masker tone and then we will give a probe tone. But the twist, what we are going to do here is that we will move the masker tone on different electrodes. So as you can see, that we will move away the masker tone from the channel where we are going to give the probe tone. And as and when the masker tone moves away from the channel of probe tone, we will see that the amplitude of the Ecap signal also increases, right? So this is how, on the right side again, you see that, for example, in this example, the probe tone and the masker were given at channel number 6. And you see on the left and right side of channel number 6 that the masker was moved away from channel number 6 and the Ecap amplitude increased. This is the typical way how you expect to see the wave, the graph, when you're using the spread of excitation function. Like you will see it like a V-shaped curve. And if you don't see a V-shaped curve, if you see a kind of a W-shaped curve, that will indicate that there is a tip fold over or something like that, which means that basically the masker, the channel on which the masker tone is and the channel on which the probe tone is, they are close. So this normally doesn't happen with the medal electrode, so we don't really emphasize a lot on this aspect. However, this task is available in the clinically released software, what you have right now on your computer, so you can do all of these tests in this task. And to make things even simpler, we also have something called as the Auto Art, which really is a nice tool, which is fast, and you don't have to do a lot in this. You just have to open the Auto Art task, you click Measure, and the software, you see that this is very nice. What we realized and we also implemented in the software is that the software is not doing the measurement in a sequence on the electrode. So it is kind of staggering the measurements. So in this example, you see that it first did the measurement on channel number 6, then it went on channel number 2, and then it went on channel number 11. So it is kind of going back and forth and staggering the measurement, because if you have to stop the measurement at any point of time, then you don't have the measurements only localized, only in a localized area of the cochlea, but you already have measurement in a quite wide section of the cochlea. So once the measurement is complete, you see very nicely, it shows the threshold of the Ecap in number, and also visually appealing is the fact that you also see green tick mark, which is kind of reassuring that you don't really have to go into the detail of the measurement. But of course, if you want to go into the details, so here you see that when I click on channel number 6, then on the right side, you see the waveform also in detail. So all of these are possible in the Maestro software, which is installed right now on your computers. How you will interpret the results of Ecap is also very simple. You see that when you increase the stimulation amplitude, then of course initially there are no responses, and then after a certain point the Ecap amplitude increases very steeply. You might also see something like this where there is constant artifact, but then you see a steep increase in the Ecap amplitude. You might also see there is a linear artifact. There might be only linear artifacts. So here in this graph, you don't see any Ecap amplitude. Here you see you see a steep curve, but just to bring your attention to the fact that this example is same as the first one, just that the x-axis starts at 400 CU. So just to bring your attention to the fact that please also always keep an eye on the scale on the x and y axis. And here you see that the Ecap amplitude is saturating at very high stimulation amplitude. So this is just for you to understand that there might be nerve saturation if you see this kind of a recording. Good. So with this, I would like to conclude and thank you all for being here so far. And if you have any questions at this point.
Thank you very much, Prem. Thanks very much for a very comprehensive covering the entire intraoperative electrophysiology on CI, and it was so fascinating to look at the intracochlear ECOG. And as of now, I think you're one of the very few person who's got more experience on intracochlear ECOG. And thank you very much for sharing that. So with that, I'll go ahead with the next presentation, and then we'll have some time for the questions at the end, if that's okay with you, Prem.
Sure.
All right. Can you see my presentation?
Yes. Still the slide. Yeah, now the presentation. Yes.
Got it. Okay. So once again, I welcome everyone for this, the first online CIGI in the history of CIGI. And I would like to thank the organizers and the scientific committee for putting up such a wonderful scientific program. So with that, I will go ahead with the second part of this this session. I'm going to talk on the electrically evoked auditory brainstem responses, which is otherwise called the EABR. So as we all know that EABR is nothing different from acoustic ABR. So the only difference is instead of giving an acoustic stimuli, you give an electric stimuli. The rest all is absolutely the same. So when you give an electric stimuli instead of acoustic stimuli, you may have to make some changes in your equipment setup and the way you record and stimulate the cochlea. So apart from that, the other components of ABR are still the same even in the EABR. So the only difference between ABR and EABR is the stimulus. So in a regular ABR, we give an acoustic, or we call it as an acoustic ABR. In an EABR, instead of acoustic stimuli, we give an electric stimuli. Now, why do you need an EABR? So what is the applications of EABR in this? The EABR is now used for multiple purpose. So one of the most important purpose of EABR is in a chronological order. It's very important to have a decision making in a gray zone candidate, whether you have to decide whether this patient needs a cochlear implant or a brainstem implant. Okay, in a very simple term, you use an EABR to assess the functional integrity of the auditory nerve. So if the functional integrity of the auditory nerve is perfect, that means the auditory nerve can transmit the electrical signals either through a cochlear implant, or you can give an electrical stimulus using on the premonitory stimulation. And also, this EABR helps to verify the adequate placement and positioning of the cochlear implant or the auditory brainstem implant during the surgery. And it helps to assist in mapping cochlear implant or ABI device to predict outcomes, which means when I mean it assists in programming in very young children where it's very difficult to establish the electrical threshold levels. So this EABR can be used as a method of predicting the boundaries of stimulation, both in patients with cochlear implants and auditory brainstem implants. And EABR also helps to predict the outcomes in challenging cases. Now, it has got two major components. If you look at the setup, you've got a stimulus, the recording component and the stimulating component. The recording component is like a regular ABR device, which has the facilities to and the parameters to acquire the EABR. The only thing is you need to have a good amplifier with a very high saturation level. That's very, very important. And if you look at the stimulation side, since the stimulation is electrical stimulation, you need to have a separate setup for generating the electrical stimulus. Now, the electrical stimulus can be generated by two means. One is either you can use the existing electrical stimulation box, which we call it as a diagnostic interface box, or other companies call it as a PPS and so on. So you can use the diagnostic interface box or the max programming interface as per the middle to generate an electrical stimuli. And to deliver the electrical stimuli, you can either use an electrode. It depends on where do you want to stimulate. If you want to do a trans-tympanic stimulation, or if you want, which means if you want to directly stimulate the round window or the premonitory, then you need a stimulating electrode connected to it. Or you can have your own electrical stimulator box, which you can design it by yourself, where this box will generate electrical pulses. Now, the only thing is you need to have a cable that connects your stimulator, which is an electrical generation box, and your recording device, which is an ABR device. Now, this stimulator is very important for the ABR device to acquire the responses in synchrony with the time. That's very important. So this is the general setup. So you have a separate setup for recording. You have a separate setup for stimulation, and the stimulation and the recording setup is linked by a cable which is called the trigger cable, which will trigger the recording device the moment the stimulus is generated. Now, the electrode montage is very similar to acoustic ABR recording, so there's no difference. The morphology of EABR is different from the morphology of acoustic ABR. Usually, the latencies of the absolute latencies are little early in EABR compared to the acoustic ABR. And the wave 1 or wave 2 may be obscured by the stimulus artifact because the stimulus itself is electrical stimulus. And the stimulus amplitude is quite higher than the response amplitude. And response is also electrical. The stimulus is also electrical. And the amplitude of the stimulus is larger than the amplitude of the response. So the response is obscured by the stimulus by itself. So you may not be able to see peak 1 or peak 2 in some cases when you do an EABR. Well, that depends on the site of stimulation, actually. The third important point is the wave 5 is typically larger in acoustic counterpart because the electrical stimulation, what I'm trying to tell is the amplitude of peak 5 in EABR is larger compared to the amplitude of acoustic ABR peak 5. This is simply because when you give an electric stimulus, the neural synchrony is much better. And the electric spread is wider, it stimulates more number of spiral ganglion cells, the more area and the inside the cochlea stimulator than the giving an acoustic stimuli. When you give an acoustic stimuli, very narrow area, the bandwidth is being stimulated. But when you give an electrical stimuli, you can stimulate a wider area so that these two components contribute to a larger amplitude of the peak 5. And similar to acoustic ABR, you can also see the amplitude growth function in EABR as well. Now, the intraoperative EABR can be recorded on by stimulating 3 important sites. Now, one is transtympanic. In other terms, you can record an EABR by stimulating the promontory directly or round window niche directly. You can record an EABR by stimulating the cochlea, stimulating the electrodes inside the cochlea, which is called the intracochlear electrodes, usually in cochlear implants. You can also record EABR by stimulating the cochlear nucleus directly in case of auditory brainstem implant. These are the 3 important sites that we stimulate when you record an EABR. Now, how is this important in decision making? Now, for example, you take a patient with a hypoplastic nerve and where it's very difficult for a surgeon or the team to decide whether this patient needs a cochlear implant or a brainstem implant, because usually the outcomes in hypoplastic nerve is very poor. And the outcomes are quite variable. It's very difficult to predict the outcomes until we implant them. So transtympanic EABR or round window stimulation EABR or promontory stimulation EABR is very useful in predicting the outcomes in these patients. So based on the responses, or in other words, you can assess the integrity of the 8th nerve or the integrity of the hypoplastic nerve. And based on the morphology, then you can decide whether this patient needs a cochlear implant or a brainstem implant or a stage 2 brainstem implant. So those decisions, this forms a very important evidence for us to make a decision on CI or ABI. Another case is in temporal bone fracture, where the patient has a severe to profound hearing loss, and if you're not sure whether the 8th nerve is preserved, where minor injuries to the 8th nerve may not be visualized in the CT scan or MRI in those cases. Now, the setup for the transtympanic EABR is very similar to the regular EABR. The only difference is you need to use an electrode which is placed on the round window or a promontory. Now, another thing is you can also do the intraoperative measures remotely as well. So this is something which we tried quite recently, and it worked out well. The first remote intraoperative EABR we tried in 2018 on an ABI patient. And this is the first remote measurement of transtympanic EABR, where we could do a very good recording, as good as doing live measurements. Now, this is a patient, she's 24 years old, who lost hearing in the left ear following a road traffic accident. And she's single-sided deafness with profound hearing loss on the left side. Temporal, the CT revealed temporal bone fracture. The plan is to go for a CA or ABI because we really don't know the auditory nerve function in this case. So we decided, we did a transtympanic EABR for her, and these are the findings. So if you look at this, there's a very nice peaks. We could measure peak 1, 2, 3, 4, and 5. All the 5 peaks we could measure. But the only thing is the peak 1 is hiding somewhere very close to the stimulus artifact here. So this is peak 1. And this peak 2, peak 3, peak 4, peak 5, and we can also see the amplitude growth. So this is when we stimulated at 300 at a pulse width of 90. And as we increase the charge level to 400, 500, you can see the amplitude and the latency shift in this case. So later we decided to go for a cochlear implant in this case. And this is a very interesting classification given by Apuru Kumar and Sunil Dutt, very good friend of us. And they have also done extensive work on transtympanic EABRs, and they even published their data. And they classified the responses into 4 categories as type A, B, C, and D. And as per their classification, the type A should have a robust wave 5 morphology with repeatable peak 3 and peak 5 with a latency of peak 5 within 5 milliseconds. The type B is good morphology of peak 5, the latency within 5 milliseconds. And the type C is fair or acceptable wave 5 morphology with peak 5 present with a delayed latency beyond 5 milliseconds. And type D is poor or absent wave 5. So it's I think probably this is one of the first classification which has been given on transtympanic EABR. And I would like to thank both of them for giving this classification for us. And the next is EABR in cochlear implants. Now, in cochlear implants, EABR is very useful to assess the functional integrity of the auditory nerve. For example, if you've already done a cochlear implant in a patient with hypoplastic nerve or a cochlear implant in patients with auditory neuropathy spectrum disorder. EABR is also very useful in making decisions to go for CA or ABI in patients who received cochlear implants in a hypoplastic nerve. For example, if the outcomes are very poor and the child is not progressing well, and we have to make the next decision whether the child whether we need to change the modality of stimulation to cochlear stimulation or a brainstem stimulation, cochlear nucleus stimulation. This EABR helps, plays a major role in it. It also helps in predicting the outcomes. It helps in assessing patients with malingering post-cochlear implant, and also helps in monitoring the auditory and non-auditory sensation. This is very interesting. Now, here is a patient with hypoplastic nerve. So he was a child who was implanted at the age of 1 year, 2 months, and the CT findings were the query, 8th nerve. And the left ear is hypoplastic now. So BOA, profound hearing loss on both ears, and aided cortical potentials, no responses. ABR and OE is absent. So we, we did a cochlear implant in both sides. This is post-CI, post 9 months ABR. So if you look at this EABR, the morphology is not very good. So you can see peak 5, but you don't see the peak 2, peak 3 very clearly here. So all that what we know is the nerve is conducting. Though the synchrony is not great, the nerve is conducting. Now I would like to show this recording is by stimulating a single electrode, and this recording is by stimulating multiple electrodes. Now this is very important. The reason why we can stimulate multiple electrodes is because in a thin nerve you may not be able to assess the population of the spiral ganglion cells, and the spiral ganglion cells may be present anywhere right from the base of the cochlea to the apical region of the cochlea. So in a patient with a thin nerve, we can't afford to lose any spiral ganglion cells. So we should be able to make the maximum use of the surviving spiral ganglion cells, which may be present anywhere between 0 to 28 millimeters of the cochlear duct. So so in that case, it's more sensible to use a longer electrode where we could stimulate the entire cochlea rather than stimulating the first turn or the first 1/4 turn of the cochlea. It's better to stimulate the entire cochlea. So if you look at this is a stimulation of the first 6 electrodes in the cochlea. So which only covers up to the first turn of the cochlea. This is by stimulating all the 12 electrodes, which covers the entire cochlea. So you see the difference in the morphology. So the synchrony is much better. We can see a consistent peak 3, which is not very evident in this when you stimulate the basal electrodes alone. So this is again a very interesting thing to look, very useful in an EABR to predict the location of the spinal ganglion cell, so that we can stimulate the entire spinal ganglion cell population as well. And this also helps you to do the frequency allocation table later in programming. So another case is a Malingering case. So he's received implant when he was 23 years old. He's a postlingually deaf, but onset is 12 years, but a gradual hearing loss. He had good hearing since switch on, and 6 months later, he complained he couldn't hear anything. He had a history of psychological issue, and he was undergoing treatment for that. So we did a EABR on his case, and we found a very good morphology. And this is a case with you have peak 2, peak 3, peak 5, very good morphology. And if you look at the previous case where the nerve is very thin, in this patient, the morphology is very poor, but still the nerve is conducting. So what we have decided in this particular case is, we've decided let's continue with the cochlear implant rather than going for a brainstem implant. Though the outcomes are a little delayed and poorer, at least we could see some kind of neural integrity, and the responses are quite consistent in this case. So there's no need to go for an ABI in these patients, because the outcomes with ABI and the outcomes with thin nerve, we don't see much difference. So there's no need for us to go for an ABI in this particular case. So this helps in decision making. And there's another interesting case with the auditory neuropathy spectrum disorder. She received implant at the age of 22. The onset of hearing loss is 18 years, and she received CI in the right ear. And post-CI, speech perception is 70% in quiet and 50% in noise. Sorry for the spelling error, with minus 10 dB SNR. The M levels were higher to achieve the loudness comfort. But however, I mean, she could only, only at a higher M level, she could have a good loudness comfort. As we increase the M level, she also had accompanied by a non-auditory sensation. Now, this is very interesting. So usually what we do is, to reduce the non-auditory sensation at higher levels, you change the modality of stimulation from biphasic to triphasic. Now, what happens is, when you use a triphasic, the non-auditory sensation goes off, but at the same time, the loudness percept goes down. Now, let's see how can we objectively measure this. Now, this is the wave morphology by with a triphasic stimuli, and this is with a biphasic stimuli. Now, look at this one. This is biphasic. This biphasic is, by default, biphasic is the preferred mode of stimulation for all the patients. But in this particular patient, so if you look at this one, this is the peak 5. And if you look at it, there is another peak here. This is nothing but the muscle response. It's a non-auditory sensational response. Now, we are stimulating at a level of 100 with a pulse width of 50. Now, the same thing, stimulation, when you change it to triphasic, okay, so you don't see the non-auditory levels. Now, if you look at the same waveform, the biphasic of 100 with the pulse width of 45, you could elicit non-auditory response here, biphasic. To elicit the same non-auditory response in triphasic, you may have to increase the charge by another 15 microsecond of pulse width here in the triphasic. Now, when you reduce the triphasic pulse width, when you reduce the pulse width of the triphasic, you see that the non-auditory response is going down. Yeah. So now, what do we understand from this? Number one, this is very useful to monitor the non-auditory sensation. Now, in this case, she's an adult, so she's able to, verbally say that she has got non-auditory sensation. But in a very young child, it's very difficult, because especially a child who's profoundly deaf since congenital, they may not be able to differentiate between auditory and non-auditory because they've never heard any sound. very louder stimulation can elicit an obvious non-auditory sensation, which is very visible even for the clinicians to look at. But sometimes the non-auditory sensations are not very visible. So, but those kind of non-auditory sensations can be monitored using this objective measures like EABRs. At the same time, you can also control the level of stimulation by looking at the change in the non-auditory response, which will be very useful for your set your stimulation levels. Now let's move on to the ABI, EABR and ABI. So you all know auditory brainstem implant is a bioelectronic device which directly stimulates the cochlear nucleus, bypassing the cochlea and the auditory nerve. So usually this is done in patients with neurofibromatosis type 2 or children who are not a candidate for cochlear implants due to anomalous inner ear and the auditory nerve. Now, the most important component in intraoperative measure in these particular patients is, number one, is preparing the patient. Now, the most, you have to have, the electrode which is placed intact. And what we usually do is, we place extra 4 electrodes. Just in case if some electrode slips out, it's very difficult to change the electrodes. So we always place extra 4 electrodes on 2 different sides. So if some electrodes doesn't work or some electrode just slips off during surgery, we can always use an alternate electrode for recording. Now, another important thing is you need to have a very isolated area for yourself to record EABR, because EABRs are highly sensitive for electrical noises. So you need to have a very secure area, isolated area for you. Okay, what is the challenge in ABI and why do we need an EABR? The biggest challenge in ABI is to position the electrode on the cochlear nucleus, because it's very difficult to visually locate the cochlear nucleus. So if you look at it, this is the cochlear nucleus. And this is just 3 millimeters. Now, to position this electrode on the cochlear nucleus is a challenging thing. So you push a little extra, it just passes the cochlear nucleus and stimulates some other nuclei. If it is too shallow, it doesn't stimulate the cochlear nucleus enough. So you need to achieve an adequate placement of that. To achieve the adequate placement of it, EABR is one of the important monitoring tools, which means the surgeon will place the electrode, you stimulate the electrode and measure the EABR, and based on the responses, you guide the surgeon to position the electrode appropriately. Now in EABR, by stimulating cochlear nucleus, you can have different types of responses. The morphology of EABR and ABI is quite variable. You can have a single peak response, you can have 2 peak response, 3 peak response, and you can even have a 4 peak response, and you may not have any response even though if it is on the cochlear nucleus at some stages. Now, the most important thing that I would like to highlight here is, if you look at the peak which is beyond 4.5 milliseconds, which is considered as a non-auditory response, which means this is a response which is not elicited by stimulating the cochlear nucleus. This could be elicited by stimulating some other neurons or some other nerves or some other nucleus on the brainstem. So this is one of our study which we published by determining the auditory zone and the non-auditory zone in the of EABR and measuring the responses by stimulating cochlear nucleus. We also looked at compared the outcomes. So we followed up 35 patients for 48 months of outcomes. We measured CAP, MACE, LEAK, SIR, and MOOSE scores. And we also categorized patients based on the number of electrodes that we could elicit responses. Now, these are 12 electrodes. All our patients used metal implants. So the metal implant has got 12 electrodes. Now, which means not necessarily all 12 electrodes has to elicit a good EABR. You may have some of the electrodes which you may not get EABR, which means those electrodes are not on the cochlear nucleus. They may be slipping little on the margins of the cochlear nucleus or may outside the cochlear nucleus. Now, for patients, those in whom we elicited more than 75% of the, patients where more than 75% of the electrodes elicited EABR. That means out of 12 electrodes, in patients where more than 9 electrodes elicited EABR, their scores are much better than the other patient. Other patients where the percentage of electrodes that elicited EABR were lesser than 75%. So this again confirms that EABR is a very good tool to predict outcomes in patients with auditory brainstem implant. To conclude, the EABR is an emerging tool for decision-making in gray zone candidates, to determining non-auditory and auditory electrodes, and also in predicting outcomes. So thank you very much. And I think we've got 2 minutes time. If you have any quick questions, we will take it. And thank you. Any questions? And
I think there is a question that I've seen in the chat box.
Apu?
Yeah, I have got received one question.
Yes.
It's on EABR for you.
Mm-hmm.
Would you be able to comment on the generation side of non-auditory sensation by looking at the EABR morphology?
Well, that's a very interesting question. It is very difficult for me to comment at the moment because I don't have enough data. That's the right answer. But when we start collecting more and more data, then we will be able to tell. But what we have, when the current study, what we are conducting now in our lab is we are trying to correlate the morphology of EABR, the latencies of the peaks of EABR, both acoustic and the non-acoustic peaks. And we also correlate with the subjective sensational measures of the non-auditory sensation. So we've just started. We're compiling the data. Maybe once we compile those data, then we will be able to clearly identify the latency of the peak, the morphology of the EABR with respect to the site of generation of non-auditory sensation. But as of now, I don't have a clear answer on that. But the patient whom I've shown here, she had a facial twitch. I think she had a twitch at the level of her, the nape of her lips and also at the eyebrows. So it's a facial nerve stimulation.
Okay, Ranjit, can I ask you a question as well?
Yes, please.
In your EABR non-auditory responses, you showed the peak after the wave 5. There were also one more recording on the top with a huge negative peak.
Mm-hmm.
Yeah, so it's usually, is it the negativity peak that is reflecting the non-auditory sensation, or the positive peak that's coming after wave 5? Which one is correlating more?
The positive one.
Positive one?
Positive one, because when we reduce the stimulation level, the positivity drops down. It's a positive which correlates.
Positive peak, okay.
Well, if there are not much more questions, then we'll move on with the next session.
Yeah, currently there are no more questions. I think if they come through, we can always put it through to you later.
All right, great. So thank you very much, Prem. Thanks for this wonderful talk, and thanks, Apurva. So maybe invite the next speaker. So can I have the? Let me stop sharing. Good. Can I have the introductory slide for Anandan, please?
I have started sharing something, so let me stop sharing, please. Yes.
Yes. Well, now we have another interesting topic. This is something very, very interesting even for me. So for which I would like to invite and introduce Mr. Dr. Anandan Dhanasinghan. Dr. Anandan Dhanasinghan is the head of translational science communication at MEDAL in Austria. So he has done his graduation from Chennai and did his post-graduation from Germany. Now, one of the work is on communicating science behind cochlear implant technology. So he is, how do I put it? I know him very well, but to put it in a very simple term beyond this slide, he's basically a biomedical engineer with a huge interest on audiology and surgical aspects of it. He has done a lot of models on cochlea, the cochlear anatomy and the nerve. And he has done a lot of work on simulating the cochlea radiologically. And he is one of the key researcher in the electrode design at MEDAL. So he has developed a lot of innovative stuffs in MEDAL, which is going to be featured very soon. And he has been one of the forefront scientists as of now in advocating for the complete cochlear coverage. And he has done a lot of research on looking at the spinal ganglion cell survival beyond the 1.5 turns of the cochlea. And I was completely astonished by his recent publication, which was published in December 2019 on the complete cochlear coverage in spinal ganglion cells. So Anandan, thank you very much for joining us. And he is now the heading a very important section in MEDAL, which is a translational research. And he has recently compiled a fantabulous a book on 30 years of translational research in cochlear implants, which is even published by Otolaryngology. Am I right, Anandan? Otolaryngology. Right?
That's correct, sir. Yes, that's correct.
So it's a fantastic book, which is around some 80 pages or so. It's worth reading that book. It covers the 30 years of translational research in cochlear implants. Anandan, thank you so much for joining us. And the most important part of Anandan that I always like to share is he's from Chennai. Anandan, over to you.
Thank you. Thank you, Mr. Ranjan, for kindly introducing me to the audience. Could you please confirm that you can see my slide first of all before I start?
Not yet. Now we can see, yes.
All right. First of all, I'd like to thank the organizing committee for having me in this conference. And it's a happy moment for me to represent MEDAL in this meeting and to talk to the Indian audience. As you all could probably imagine that if a pediatric patient is implanted at the age of 1, let's assume, then after every 20 years, the child has to undergo reimplantation surgery in order to replace the implanted device. And to preserve the intracochlear structures throughout in all these reimplantation surgeries, on top of the atraumatic surgical techniques, what we have right now, the electrode that goes inside the cochlea should possess certain characteristics. And in this presentation, we will try to understand what those key characteristics are that makes an electrode to be the ideal one in preserving the structures and as well in covering electrically most of the neuronal elements. And before we go into the details of electrode, let's try to understand the environment in which any electrode would be placed, and that is the scalar tympani. And what we see here in this slide is the endoscopic view of live human scalar tympani. And you all can see that there are like hundreds of blood vessels that are running along the floor of the scalar tympani. And on the roof of the scalar tympani, you can see where the basilar membrane or the organ of Corte is there. That's where the delicate hair cells are present. And here is the outer wall, or also called as lateral wall, which is very smooth in surface. And along the outer wall is where all the straight electrodes, including the flex electrodes from MEDAL, would slide along. And here is the inner wall, or also called as modulus wall, which is pretty rough in texture, as you all can see that, and it's highly porous. And inside the modulus wall is where the spiral ganglion cell bodies are present. So this is the environment in which any CI electrode would be placed by the surgeon. And if we consider how an ideal electrode insertion should be. As you can see that the ideal electrode insertion should be in a way that the electrode should go freely inside the cochlea as deep as possible without giving any resistance. And after the electrode reaches to its full length, we should be able to see that the electrode is fully residing inside the scalar tympani without causing any degree of damage to the intracochlear structure. So this is considered as the ideal situation, and this is what we envision in every CA surgery to happen. But in the real world situation, depending on the electrode tip geometry, let's take that for example, and depending on the tip geometry, it can be that in some cases, electrode tip foldover could happen. So this is considered as one of the electrode related issue. And depending on the stiffness of the electrode, it could be that in some cases, the electrode can penetrate through the spiral ligament and move from the scalar tympani to the scalar vestibuli. And this is considered as one of the severe degree of damage to the intracochlear structure. And again, this is considered as one of the electrode-related complication. And depending on the electrode length, if the electrode length is short, for example, let's take it that way, then the short electrodes can only cover the basal turn of the cochlea, leaving the middle turn of the cochlea without any electrical stimulation to that particular region of the cochlea. And so therefore, these three are considered as the electrode design related issues. And considering or like talking about the characteristics of an ideal electrode should literally have a 0% incidence rate of tip foldover, and an ideal electrode should possess a very low incidence rate of this scalar deviation. Plus, this electrode should be long enough to go physically into the second turn of the cochlea in order to provide electrical stimulation to the entire population of the neuronal elements. So in this presentation, we will try to look at all those recent published evidences and try to find out which electrode type possess all these characteristics of an ideal electrode. Now let's take the electrode tip foldover issue as such as the first electrode design related issue. And now let's look at the published evidences and try to understand what is the incidence rate of electrode tip foldover with every electrode type, including the flex electrode. And what we see in this slide is a very recent published article. In fact, it was published last month. And it's a joint report coming from Munich and Rostock Clinic from Germany, in which they have analyzed 378 consecutive cases of CI patients that were implanted with FlexSoft electrode, and analyzing the post-operative image of all these patients, they were unable to identify a single case with tip foldover. And plus, they also reported that in all these 378 cases, the long length electrode, which is the FlexSoft, were able to place it fully inside the cochlea, which is a very good result that summarizes how safe a flexible electrode can be to the intracochlear structure. And in this slide, it's a kind of a literature review that we have done at MEDAL so far. And we have seen so far like 26 articles that were reported on electrode tip foldover in particular, taking all the electrode types that are available in the CI market, covering all the CI brand. And what we found out was that the incidence rate of electrode tip foldover associated with pre-shaped electrode can be as high as 5.3%, whereas with the straight lateral wall electrode, regardless of the CI brand, here I'm not just talking about the MEDAL electrode, but then like placing all the straight electrodes into one category, and we were able to see only 0.5% of the incidence rate. What it means is that like if 100 patients are implanted with a pre-shaped electrode, then the chances are there for 5 to 6 patients to have this tip foldover. Whereas if 100 patients are implanted with straight lateral wall electrode, then literally one patient, if not no patient, will have this tip foldover. And it's very important to see these published articles, especially from the year 2020, and they all report that the electrode tip foldover is mainly associated with a slimmer form of the pre-shaped electrode, which should be taken note by the audience. Now, talking about the scalar deviation, this is again another electrode design related issue. And in fact, like this has a direct negative impact on the post-operative hearing of patients with the help of cochlear implants. And again, doing a detailed literature review covering almost 38 articles that reported on the electrode scalar deviation, covering all the electrode types that are currently available in the market, capturing all three major CI brands, we found out that the incidence rate of electrode scalar deviation with the pre-shaped electrode can be as big as 30%, whereas the incidence rate of scalar deviation with the straight electrode, including the flex electrode, the incidence rate can only be 11%. So all the electrodes what we have at middle will fall under the straight lateral wall electrode category. And I don't know like how the patient counseling happens. Whoever is involved in this patient counseling, be the CA surgeon or the audiologist or the rehabilitation professional, they should take their time to read all this literature, to update their knowledge in order to give a kind of an honest opinion when they are doing this patient counseling, especially when selecting the CI brand. Now, let's try to understand like how far inside the cochlea is the distribution of the spiral ganglion cell bodies before we talk about how deep inside the cochlea should be provided with the electrical stimulation. A detailed literature review, again, literature review of articles that reported on the distribution of spiral ganglion cell bodies conveyed us the message that, so here is the basal turn, and beyond the basal turn, there is almost like 25% of the total number of spiral ganglion cells. And this is equivalent to a bit more than 7,000 neuronal cell elements that are present beyond the basal turn of the cochlea. And in fact, this is true for any pathological reasons of hearing loss, be it like meningitis reason or any reason of hearing loss. The segment 4 always has approximately 25% of the neuronal cell bodies. More scientific fact pointing to the same message that here is published evidence that came out more than 30 years before. With the help of the 3D reconstructed model of the cochlea, they were able to identify the presence of spiral ganglion cell elements up to 720 degrees of angular insertion depth. The green structure, what you see in this picture, represents the spiral ganglion cell bodies. And last year, using the high radiation image of the human cochlea, a group from Canada and Sweden, they were able to identify the spiral ganglion cell bodies that are present all the way to the end of the second turn of the cochlea. And this being the scientific understanding, if a pre-shaped electrode is placed covering only the basal turn of the cochlea, the second turn of the cochlea, you can see that will be literally left without any electrical stimulation. And this might prevent the patient from having the full benefit of the CI device. Even with the basal coverage, the patient may be able to understand something, but from the patient perspective, this is already a kind of a very good improvement. But in case like if those patients are also provided with electrical stimulation to the second turn of the cochlea, maybe those patients can hear much, much better than what they are currently hearing with only the basal coverage. And this slide gives us an idea about the average angular insertion depth provided by all the electrode types that are currently available in the market. So if we take, for example, a pre-shaped electrode, on average, it covers only an angular insertion depth of 385 degrees, which is only the basal coverage, meaning that the second turn of the cochlea will not be getting any electrical stimulation. And when we take the standard or flex soft electrode, the average angular insertion depth provided by these two electrodes is 610 degrees, which is very much into the second turn of the cochlea. And taking the flex 28 electrode, on average, it covers an angular insertion depth on average of 548 degrees, which is again well into the second turn. And taking all the medium electrodes, medium length electrodes, for example, flex 24 or medium length electrode from Medel, or slim straight from Cochlear, or slim J from Advanced Bionics, all these electrodes can cover on average approximately 400 degrees, which is really not much. That means those patients may not have the chance to get their second turn of the cochlea electrically stimulated. And so far, there are a good number of quality publications that report on the relation between, a positive relation between the angular insertion depth, as you can see in this x-axis, and the hearing score of the patient using the CI. And there is a clear positive correlation. What it means is that as the electrode goes deep inside the cochlea, the patients tend to hear much, much better. And in fact, this is true for a CI device from any CI brand, not just from Medel, but any CI brand, as long as their electrode goes deep inside the cochlea, you will see that the patients are getting a better benefit. And all those evidences, what we have seen so far in the previous slide, they are the scientific reason why MEDAL keeps insisting on implanting the longer length electrode in order to place the electrode physically into the second turn. Thereby, you provide the possibility of having electrical stimulation in the second turn of the cochlea for those patients. And this is a chart where you can see all those different cochlear anatomies, what you can see from the literature that are shown in this top portion of this chart. And down in this chart, you will see that all those electrode choices, what MEDAL is offering in order to provide a perfect match between the cochlear anatomy and then the electrode length. And really, MEDAL is proud that this is the only company offering such a wide variety of electrode variants in order for surgeons to choose the best electrode that fits to the patient's cochlear anatomy. And to summarize, as you all seen that based on the recent literature evidences from 2020 and 2021, we can say that flexible lateral wall electrode, including the flex electrode from MEDAL, is considered as the most atraumatic electrode, and they have the least incidence rate of electrode tip foldover issue, and so is the electrode scalar deviation. And again, the scientific fact points to the direction that beyond the first turn of the cochlea, there are almost 25% of the total number of neuronal elements, and that should not be missed with electrical stimulation if you provide a shorter length electrode. And that's the reason why MEDAL keeps insisting to go for the longer length electrode. And again, MEDAL, I'm happy to say that MEDAL is really proud in offering different electrode variants in order to provide a perfect match between the cochlear anatomy and then the electrode length. If I can take another half a minute, I can say that last year, MEDAL was happily celebrating its 30th anniversary in the CI field. And on that occasion, our CEO, she has returned a compendium. This is what Ranjit was saying in the introduction. And in this compendium, we have covered all those key literature studies that helped MEDAL in bringing hearing solution for several hearing loss indication. And we would like to take this occasion to thank hundreds of clinicians who stood with MEDAL to support in our scientific journey. And as a result, today we are standing as a strong CI partner for all the clinicians where we are. And that's pretty much the message I wanted to convey to you all. And I sincerely appreciate all your time and interest listening to this presentation. I wish you all the best and thank you.
Thank you very much, Anandan. That was quite comprehensive. You just made a 15-hour subject in 15 minutes. Thank you so much.
Thank you, sir.
It was very clear and very precise. And without wasting much time, I'll invite the next speaker. Our next speaker is a very famous personality in the field of cochlear implants. So may I invite Dr. Peter Knopp. Dr. Peter Knopp holds a diploma in engineering degree, which is equivalent to an MSc, and a PhD in electrical engineering from the Technical University of Vienna in Austria. He joined MEDAL in 1996 and currently is a director of research and in signal processing. Dr. Peter Knopp is the company expert for coding strategies, signal processing, fitting algorithms, and related questions. So Dr. Peter Knopp is an author of numerous peer-reviewed publications and holds several patents. Peter, thank you so much for joining us, and over to you. Is Peter here? Prem, do we have Peter here?
I don't see him, Ranjit. I'm just trying to contact him.
Okay, in the meantime, do you have any questions to Anand? Apurva, could you pick any questions for Anand if there is something?
So I must just say it was a very comprehensive presentation and very, your slides on the anatomy and were excellent. Just wanted to tell that. Yeah.
Thank you, Dr. Sandra.
Anand?
Yes, Mr. Ranjit.
Anand, I have just a small clarification from your side based on the research, what you have done. So I was looking at one of the publications from Shumit group from Canada. Yes, so they were just they did the synchrotron study, and they were just showing something called the hook region, which is quite new even for me in the anatomy. I've never looked anything into it during my university time. Could you highlight some little more on that, the hook region?
Yes, what they done was that they were able to capture the basilar membrane separately. And I mean, I was thinking all the time that the basilar membrane starts where the round window opening is. But what they identified is that the basilar membrane goes a bit beyond the round window, and there is almost 2 millimeters of basilar membrane that goes behind the round window membrane. And that is something kind of a new finding because of that high contrast imaging that they were able to find it. I think this is, to my understanding, what they call as the hook region.
Interesting. Because even I have never studied anything about the hook region during my university times. So which means that, based on the studies, what you've got quite recently, our understanding of the anatomy has to be, relearned, unlearned and relearned. Absolutely. Anatomy of the microanatomy of the cochlea. So.
That's true, sir. Yes.
So another question, just in MEDAL, do you also have any, do you also develop something, where it's easy for the surgeons to monitor the, the incision, like a kind of, we have this cochlear endoscopy. Is there a way that you can have a small camera or a kind of a feedback system which will guide the surgeon whether the electrode is going on the scala tympani or if there is going to be a scala deviation? Is there any kind of a feedback mechanism that it's that you have it with you?
I think Prem is the right person to answer this question. I think with this ECOG, I mean, the research are going on, but I'm not the right person to talk about that. But with those help of ECOG, it should be possible in the near future to find out whether the electrode is touching the basilar membrane or not. And in case if the electrode is touching the basilar membrane, it should give some feedback. With that, either the surgeon can retract the electrode a bit and then try to push it. I think Prem, maybe you can add something to this question.
Yes. Yes, Anand. Sorry, I just have an update from Peter. He had problems with the laptop. Everything okay now, so he should be joining anytime. Okay. Ranjit, yes, to answer your question, when the patients have any measurable residual hearing, then we can do electrocardiography measurement. And in fact, even if the threshold, so I have personally done measurements at threshold of even 100 dB HL. So even at high degree of hearing loss, we can do the electrocardiography measurement. But at the same time, we are also in the process of developing some other tools where even if the patient has no measurable hearing, we will still be able to monitor the depth of electrode insertion. So we are certainly working on it, and we have some very, very positive outcomes so far.
Yeah, because this is something which I face when I do the intracochlear ECOG. So as you keep slowly inserting the electrode and keep measuring the ECOG, the amplitude increases when the electrode tip goes very close to the site of generation. And then suddenly the amplitude goes down. So the question is whether the electrode is passing over that area, or is some scalar deviation. And that's something which I was a little skeptical. So that's why I thought maybe if there is some other feedback mechanism that will help us to
Yes, Ranjit, I have a very interesting observation in that direction, and that is that of course, when you go past the signal generating side, then the amplitude will decrease, but it should not drop and go zero. First thing. Second is that if it goes zero, then with the med electrode, at least we can say that because the tip is so soft and flexible, that most probably the basilar membrane movement has got dampened. So what you can do is just pull out a millimeter, and then you will see that the amplitudes will recover. So it's highly unlikely that you've done a damage, but technically if it goes zero, that should indicate that there is a damage, there is a basilar membrane deviation. But with MEDAL, you pull it out a bit and then it normally recovers. And this also gives a hint very nicely for EAS fitting, that if you dampen the basilar membrane movement, then the acoustic is not going to work later on in the fitting. Correct. So it's very interesting to work with the ECHO-G and residual hearing.
Nice.
So Peter said that he is fine, but we still don't see him here, right?
Anand, there is one question for you. So what do you think is the function of the hook region, if you know?
I'm not prepared to answer this question, but then like what I know is that like because we know that there is a hook region of 2 millimeters behind the round window, the frequency allocation I think will need to be changed. The Greenwood's frequency function won't be any more accurate. So that needs to be readjusted. I think Dr. Sumit and the professor from Sweden, they are trying to remap, like to come out with a new frequency map. With that, one can do a better fitting. To my understanding, this is what like they are like working on, and soon that will be implemented in the Autoplan software.
Interesting.
Yes, this will help us. Yeah, we are already doing work on it. This will help us in getting a more accurate tonotopic-based fitting.
I think Peter has joined.
Yes, Peter is here.
Hello, Peter.
Peter, you need to unmute, please. Yeah.
I am unmuted now.
Peter, we can hear you.
Yeah, and right.
Thanks for coming, Peter. So,
yeah, thanks also for waiting for me. I had problems getting my laptop started.
Okay. So we'll go ahead. So can you make it your presentation within 10 minutes, if that's possible?
Yes, I can do that. No problem. No problem. And really, I apologize again. Sometimes technology develops its own character. I'm just opening my PowerPoint and now I'm sharing.
I've already introduced you to the audience.
Right. Okay, that's great. And again, excuses to the audience for the delay. Okay, you should be able to see my PowerPoint now.
Yes, we can see it. Can you?
Right?
Yes.
Okay. Okay. Thanks for your patience. And again, I apologize. I started switching up my laptop. I thought right in time, but then something didn't work. Okay. This is about how we at MEDAL aim to really provide as natural hearing as possible through our cochlear implants. And I'm really happy that I have a chance to present to all of you out there in India and other countries in the area. It's really a pity that we are hit by the pandemic again, or still, and I really hope that next year things are over and we can meet in person. Closest to natural hearing through a cochlear implant was really always the center stone of our development effort and of our design goal. And as such, the signal processing in natural hearing really always was the blueprint of what we were aiming for, from the outer ear through the middle ear and into the inner ear. And I'll talk about three aspects today that are specifically located in the inner ear and that are known to be specifically of importance in natural hearing. And what I'll show is how we take care of those processes in the MEDAL cochlear implant system. These are the traveling wave, tonotopicity, and phase locking. Tonotopicity and phase locking both are important aspects of pitch, and the traveling wave, as you will be seeing later, is an important aspect in spatial hearing. Okay, let's start with tonotopicity. We all know that the entire cochlea is a hearing zone, from the very high frequencies that produce neural responses towards the base of the cochlea, through all of the other frequencies to the very low frequencies that produce neural responses in the apical region of the cochlea. And if we want to model that aspect, that important aspect of tonotopicity, as naturally as possible, so to speak, then we really need to build a cochlear implant that can stimulate the high frequency region in the cochlea, as well as the mid frequency regions in the cochlea, as well as the important low frequency regions located in the apex of the cochlea. So we really need to develop a system that allows us to cover the entire cochlea in each user out there as completely as possible. So we really need a system that allows us to achieve complete cochlear coverage in each user as much as possible, and not only design a system where the electrode maybe only sits in the basal turn in the cochlea or only in the apical turn of the cochlea. Now, this is really what we were aiming for, or what we are aiming for at MED-EL. Now, unfortunately, not all cochleas are equally long. There are short cochleas and there are long cochleas. And this means that in turn, for allowing complete cochlear coverage in each cochlea, in each single cochlea, we need to offer short electrodes for short cochleas and long electrodes for long cochleas. And that's really what we're doing at MED-EL through our electrode portfolio, from the long Flex Soft down to the short Flex 24 for long cochleas and short cochleas. And we're also providing a tool which is called Autoplane, where based on a preoperative CT, you can measure cochlear lengths, and then based on the length of the cochlea that's shown here, select the appropriate electrode for the particular cochlea to be implanted next in your OR. So complete cochlear coverage really is a central aspect of our system. Now, the next thing is phase locking. Not only does tonotopicity determine pitch, but also phase locking determines pitch. Phase locking takes place in the low frequency region, where the low frequency tone sits, and phase locking in the low frequencies below 1 kilohertz or 1.5 kilohertz is really thought to be a more important element of pitch, a more important code of pitch that the brain receives than tonotopical place. Now, in order to model this one, or in order to also consider that aspect in the cochlear implant system, we've developed fine hearing technology and fine hearing coding strategies like FS4, FS4P, FSP. And what we're doing in these strategies is that we treat the apical region of the cochlea special. Throughout all the other cochlear regions, we use constant high rate stimulation rates, but in the low frequency region, we really stimulate, we use sound rate stimulation, which means we stimulate the nerve in synchrony with the sound wave in order to, again, produce phase locking as it's normally produced in the cochlea, so that throughout the entire cochlea, the brain receives neural responses, receives information that comes as close as possible to what the brain would receive if out there wasn't a cochlear implant, but the normal hearing cochlea. That is what I call the ideal cochlear implant, or striving towards the ideal cochlear implant, where the brain wouldn't even notice that there is a cochlear implant out there and not a normal hearing cochlea. And all I'm showing you now, or all I'm showing you today, is really everything we can do today possible in our system to come closer and closer to that ideal cochlear implant. So sound rate stimulation in the apical region to reproduce normal low frequency pitches is again a very important aspect that builds on complete cochlear coverage and goes beyond complete cochlear coverage. Now, all of those aspects, of course, also have to do with fitting. the Medel cochlear implant system is designed to as closely as possible to nature, cover the entire cochlea, then also in terms of the frequencies and the information that is provided through each electrode on the array. This is an average case for a Medel cochlear implant recipient. In green are the tonotopical electrode frequencies, and in gray are the frequency ranges that are assigned to these electrodes by default through the Maestro fitting software. And as you can see, and this is actually how it was designed, as you can see, for the default and average situation like this, most of the frequency bands really nicely overlap or nicely correspond to where the respective electrode contact sits in the cochlea. So on average and by default, in an average Medel user, the natural tonotopical arrangement of the cochlea is already nicely followed by default. However, in individual cases, of course, there can occur deviations between where the electrode contact sits, again in green here, and the default frequency band. And this is for a very deep insertion, for example, of 720 degrees. Now, we have developed another element in our system that allows us to, in a case like this, close the gap that occurs here between where the electrode sits and the frequencies that are designed to a particular electrode contact. Like, for example, in this case here, where the gray band is somehow offset from the green point, right? And this is, again, Autoplane and Maestro. In Autoplane, based on a postoperative CT, you can measure individual tonotopical frequencies for each electrode contact, and then you can that information can be exported from Autoplane, imported into Maestro, and then in Maestro, either by hand or automatically, you can adjust frequency bands so that they better correspond to where in each particular case the electrode contacts sits in the cochlea. We call that anatomy-based fitting, and that is maybe in a certain patient, the icing on the sugar, right? It still relies on complete cochlear coverage. We cannot stimulate the cochlear region that's not covered by an electrode array, but what we can do through anatomy-based fitting really is providing then the icing on the cake. The cake is CCC, the icing on the cake is anatomy-based fitting, and close any remaining gaps or remaining discrepancies with natural tonotopicity. And what this all produces, as was shown in a paper in 2016 already, if we carefully match tonotopical place in the cochlea and stimulation right, like through fine hearing technology, is then basically more or less completely natural pitch. In green is the Greenwood function, that is the natural pitch function. And the measurement points here are what was measured from SSD users with a cochlear implant on the one side and normal hearing on the other side. And as you can see, in the case where stimulation rate and tonotopical place were carefully matched, we can almost perfectly recreate natural tonotopical pitch through a cochlear implant. Now, the last element I would like to talk about is the traveling wave. The traveling wave is an important element when it comes to match two ears in a case where a cochlear implant on the one side correspond or is used in combination with some form of normal hearing or natural or acoustic hearing on the other side, like in SSD users and bimodal users, as I will be showing you in the last 2 minutes of this presentation. This is EABR latencies as measured from a normal hearing ear. And what you're seeing here, that latencies increase from high to low frequencies. And that is, of course, a result of the traveling wave mechanics in a normal hearing ear. And as you can see, this other curve is the same EABR latencies measured from a Medel cochlear implanted ear. And as you can see, these latencies, at least qualitatively, nicely correspond within certain limits, of course, within maybe 1 or 2 milliseconds, but it qualitatively nicely correspond to what we are seeing in the normal hearing ear. And that is increasing latencies with decreasing frequency. So that means that Medel also nicely matches basilar membrane mechanics in the normal hearing ear, which makes Medel particularly well suited for SSD users. Now, what if in the other ear there sits a hearing aid? What if we are not confronted with an SSD user, but with a bimodal user? Then in the other ear, the EABR latency function is in the other ear, the EABR latency function is like this. It's shifted up by the fact that the hearing aid adds a delay to the normal hearing ear, which is about something usually between 7 and 9 milliseconds. So that function is shifted up. In order to compensate for this delay in a bimodal user, Medel has developed technology which is called bimodal synchronization that now allows to also shift up the CI curve in the Medel processor. You can add a certain delay in the Medel processor to compensate for the delay that occurs in the hearing aid. And that is called bimodal synchronization. And that feature makes then Medel particularly well suited, not only for SSD users, but also for bimodal users. And both of these elements have their benefits. This is results from SSD users in Medel, 4.8 dB for head shadow, 1.4 dB for summation, and 1.3 dB for squelch when we talk about spatial hearing and spatial release from masking. And these benefits from a Medel cochlear implant in an SSD user compare very well, which was with numbers that were published for other cochlear implant systems where much lower benefits were found. So this is really why I'm saying Medel is particularly well suited in SSD users, but Medel is also particularly well suited in bimodal users. This is how bimodal users benefit from this feature of bimodal synchronization that I just addressed. This is sound localization in the frontal horizontal plane with users with fast hearing aids and slow hearing aids. So with hearing aids that have a delay below 3.5 milliseconds and that have a hearing aids delay of larger than 3.5 milliseconds. Condition A is without bimodal synchronization. Condition B is with bimodal synchronization. And as you can see, especially for users of standard hearing aids, these are Widex hearing aids that are relatively fast, but most hearing aids have delays between 7 to 9 milliseconds. For users of most hearing aids, if bimodal synchronization is activated, then sound source localization improves instantly, and it also stays improved over a certain period of time. And if after that period of time bimodal synchronization is switched off again, then sound source localization goes back to poorer, so to speak, instantly. So bimodal synchronization really allows bimodal Medel users better spatial hearing through a feature that is unique to the Medel cochlear implant system. So all in all, the fact that we really, and I've devoted my life to that technology, really, that's why I'm really getting emotional here. The fact that we really always used normal hearing as a blueprint for our development efforts through the outer ear with natural directionality, the middle ear and the inner ear with the traveling wave, tonotopicity, compression, phase locking. All of those efforts really now show benefits, especially in terms of more natural pitch in the low frequencies, through complete cochlear coverage and fine hearing technology, and also better results in SSD and bimodal users through better modeling or better recreation of the traveling wave mechanics and bimodal synchronization in our system. And I hope that my presentation was worth the time you've been waiting for, and I thank you for your time. Thank you very much.
Thank you, Peter. Thank you so much, and definitely it's worth the waiting for your presentation. And I thoroughly enjoyed all the presentations. And thanks to Prem, Anand, and Peter. You guys are doing a wonderful job at MEDAL, and all three of you explained the complete cochlear coverage, right from the electrode incision, the types of electrode, and different measures along the cochlear duct, and also the speech coding strategy and the sound coding techniques. So thank you very much. And I also thank the organizers for giving the extra time for Peter, and thank you once again.
Yeah, thank you also. Thank you. Really, again, I'm sorry for the delay.
Thank you, Ranjit. Thank you, Ranjit, and all the panelists. Great insights across the electrophysiology, electrode length, and also the processing of sound. Thank you very much to all the panelists and Ranjit. Thank you.
Thank you.
Thank you.
Couple of housekeeping tips, housekeeping things before we close the audiology session here. We will now move on to the hall 1, that is the surgery hall for the last session, and then that will be followed by the general body meeting of CIGI. Tomorrow morning, it's an early start at 7 a.m. Hope to see you all, and in the morning tomorrow at 7 a.m. start. Thank you. Let's move to the other hall now.